Hello everyone, welcome to Let's Learn Patho. This is part 2 of lung cancer. In part 1, we have already discussed about the introduction of lung cancer, its etiology, what is the reason for development of lung cancer in never smokers, classification of lung cancer and details of squamous cell carcinoma and adenocarcinoma. In this video, we will talk about the neuroendocrine tumors of lung, which include small cell carcinoma, carcinoid tumors and benign tumorlet. Then a bit about large cell carcinoma, and in the last part, we will discuss the metastatic tumors of lung. Starting with the small cell carcinoma is most strongly associated with smoking, and the common mutations seen here are T53 gene mutation, RB gene mutation, and MYC gene mutation. It can involve the peripheral region of lung or hilar region of lung, and it is highly malignant and aggressive in nature. This is the reason why there is no pre-invasive phase seen in case of small cell carcinoma, and small cell carcinoma is having worse prognosis among all the lung cancers. After that, let's discuss about the morphology of small cell carcinoma. The cells here are small. They are smaller as compared to 3 times of the size of small lymphocyte. Then they are having scant cytoplasm and their chromatin is finely granular, giving rise to salt pepper appearance. The phenomena of nuclear molding is seen in case of small cell carcinoma. Mitotic count is high and extensive necrosis is present. Apart from that, Azzo-Party effect is seen in case of small cell carcinoma. This is nothing but the basophilic staining of vessel walls due to the nuclear chromatin released from necrotic tumor cells. So this is the slide of small cell carcinoma of lung. Here you can clearly see there are small tumor cells which are having scant cytoplasm and finely granular nuclear chromatin and basophilic stained vessel wall due to Azzo-Party effect. After that, on electron microscopy, dense core neurosecretory granules are seen in the cytoplasm, and this is diagrammatic representation of a typical tumor cell which is seen in case of small cell carcinoma. Here you can see salt pepper nuclear chromatin and dense core neurosecretory granules in the cytoplasm which store synaptophysin and chromogranin. On immunohistochemistry, small cell carcinoma is positive for synaptophysin, chromogranin and CD56. After that, let's discuss about the carcinoid tumors of lung or bronchial carcinoids. They are low-grade malignant epithelial neoplasms and there is no gender bias. That means it affects male and female equally. And the common age group affected is less than 60 years. The pre-invasive lesion seen in lung carcinoids is DIPNEC, that is diffuse idiopathic pulmonary neuroendocrine cell hypoplasia. After that, coming to gross features of carcinoids, the carcinoids can be peripheral in location or they can be central in location. The peripheral carcinoids affect the small airways which are present in periphery of lung, and the central carcinoids affects the main bronchi which is present in the central region of lung. The central carcinoids are more common. They are seen in approx 80% of the cases, and these are further of 2 types. They can be intraluminal, which protrudes into the bronchial lumen, and they can be peribronchial, which penetrates the bronchial wall and spreads in peribronchial tissue, producing a collar button lesion. So this diagram is showing the 2 types of central carcinoids, which can be intraluminal or peribronchial. This diagram is showing spherical carcinoid which is protruding into the lumen of bronchi, and here in this diagram you can see that the carcinoid is penetrating the bronchial wall and spreading into the peribronchial tissue to produce a collar button lesion. After gross features, let's come to the microscopy. In microscopy, you can see that the tumor cells are arranged in an organoid or rosette-like pattern which are separated by fibrovascular stroma. So this is the slide of lung carcinoid which is showing the organoid arrangement of cells separated by fibrovascular stroma. On electron microscopy, dense core neurosecretory granules are present in the cytoplasm, and upon immunohistochemistry, the lung carcinoids are positive for serotonin, neuron-specific enolase, bombesin and calcitonin. Coming to the types of lung carcinoids, they can be of two types, typical or atypical. Typical carcinoids are showing slow growth and less metastasis, while atypical carcinoids have fast growth and more metastasis. There are less than 2 mitotic figures per 10 high power field in case of typical carcinoids, and more than 2 mitotic figures per 10 high power field are seen in case of atypical carcinoids. No necrosis or hemorrhages are seen in typical carcinoids, and necrosis and hemorrhages are seen in case of atypical carcinoids. Then in the blood, the levels of serotonin and chromogranin A is high if it is typical carcinoid. While in atypical carcinoids, the blood levels of serotonin and chromogranin is normal. Then coming to clinical features, the clinical features of carcinoids are mainly due to three reasons. Due to the intraluminal growth of the carcinoid, metastasis of tumor, and release of vasoactivins, that is due to secretory activity. See, most of the carcinoids do not have the property of metastasis and they do not have secretory activity as well. So the main clinical feature of carcinoid is due to the intraluminal growth only, which includes the hemoptysis, which is most common presentation seen in case of carcinoids. And this intraluminal growth is also responsible for impaired drainage of the respiratory passages, leading to symptoms like persistent cough and secondary infections. After that, let's discuss about the carcinoid syndrome. See, what happens in around 10% of the carcinoids, the lung tumor metastasizes to liver and impairs hepatic metabolism. So the hormones produced by tumors like serotonin, which normally gets inactivated by the hepatic metabolism, will bypass the hepatic metabolism and they will enter systemic circulation, producing systemic side effects like diarrhea, flushing and bronchoconstriction. After carcinoid tumors of lung, now let's discuss a bit about the benign tumorlet. It is not that important. We just have to know that benign tumorlets arise from type 2 pneumocytes in response to chronic inflammation and scarring. After benign tumorlet, we'll talk about the large cell carcinoma of lung. Large cell carcinoma of lung is undifferentiated malignant epithelial tumors. Here, undifferentiated means that they are not having typical patterns like seen in case of adenocarcinoma or squamous cell carcinoma. The cells seen in large cell carcinoma are having large nuclei, prominent nucleoli and moderate amount of cytoplasm. This is the slide of large cell carcinoma of lung, which is showing pleomorphic cells. And pleomorphic means the cells will vary in their shapes and sizes, and all these cells are having large nuclei, prominent nucleoli and moderate amount of cytoplasm. Then the diagnosis of large cell carcinoma is exclusion based. That means whenever any tumor is diagnosed, it is tested for immunohistochemistry, and if it is not adenocarcinoma, squamous cell carcinoma or small cell carcinoma, then it is diagnosed as large cell carcinoma. So the diagnosis is exclusion based. Then there is a histological variant of large cell carcinoma, which is known as large cell neuroendocrine carcinoma. The molecular features of large cell neuroendocrine carcinoma is similar to squamous cell carcinoma, except that the cells here are of larger size. After large cell carcinoma, now let's discuss about the metastatic tumors of lung. See, till now we have discussed about the primary tumors of lung. Primary tumors, that means they arise in the lung itself, which includes adenocarcinoma, squamous cell carcinoma, small cell carcinoma or large cell carcinoma. Now we'll talk about the metastatic tumors. What happens in metastatic tumors is that the tumor develops at some primary site, and then from this primary site, tumor metastasizes to lung via lymph, blood or direct continuity. The metastatic tumors are more common as compared to primary tumors, and the most common primary tumors which metastasize to lung are osteosarcoma in case of a child and breast carcinoma in case of adults. Then in metastatic tumors of lung, coming to morphology or the gross features, you can see multiple discrete nodules in the lung which are known as cannonball lesions, and these lesions are scattered throughout all lobes, but they are particularly more common in the periphery of lung. So this is the Metastatic tumor of lung showing cannonball lesions.